Well, good afternoon, everyone, and welcome to the health portion of our 2020 virtual convention. This afternoon, we're going to be talking about New Jersey and COVID-19 and its impact within our community. We are pleased to have this very esteemed panel share a wealth of knowledge with you regarding this pandemic that has changed how we all live our daily lives. I am going to introduce the moderator, Dr. Christina Johnson, who is a physician at Maplewood Family Medicine and is on the faculty at Overlook Family Medicine. She was born and raised in Philadelphia. She is a board-certified family medicine physician. Her professional interests include preventative medicine, community medicine, and primary care research. In her spare time, she enjoys spending time with her family and friends and loves to learn about art and music, which is a great thing since we were listening to Marvin Gaye in the green room. So now I turn it over to Dr. Johnson, who will lead our panel. Thank you.
Unmuted. Good afternoon, everybody. I hope everybody's been enjoying the conference so far. I hope everyone can hear me okay. I have adjusted the volume. So please, in terms of just housekeeping issues, please have your computers on mute, which I think you're automatically muted. You can enter questions into the chat or into the Q&A for the Q&A session a little bit later, but I'm not going to belabor this panel. We have a rich discussion coming up, and we're actually going to get started with our first panelist. We have Dr. Judy Banks, who is an entity in New Jersey. She probably has delivered some of the participants here, or has worked with some of the participants here and their families and their children. She is an obstetrician and gynecologist, was in private practice, but is currently associate director over at Morristown at the teaching practice in obstetrics and gynecology. So if Dr. Banks can go ahead and get started. She's going to start with her presentation, and we look forward to hearing what she's going to share with us related to COVID-19 and OBGYN. Dr. Banks? Just unmute yourself, and then they will pull up your slides. There you go.
Hi, good afternoon, everyone. So it's a pleasure to to be here with you, and just to talk a little bit about women's health from a clinical standpoint as a obstetrician gynecologist here in this time of COVID-19. So COVID-19 really changed a lot in a very short period of time, and certainly in the outpatient clinical setting. One of the things that happened was that providers and patients had to get used to the virtual visit in a very short period of time. The reality is that telehealth is not that popular originally here in the Northeast Corridor, but it's a modality that has been used throughout the country, actually, for many, many, many years, and is a very effective tool in communicating with patients, used more widely in areas where perhaps there are rural settings and there's not a lot of availability of providers, though its continued use has certainly shown that there is a lot that can be done to deliver health care, and in many ways it can be highly effective or even more effective. So let's see, can I have the next slide, please? So just like the digital platform has been used for communication, a lot of things have been going on in medicine, a lot of changes that took place before COVID. But we know that the electronic medical record has made data available to us, and that a lot of things that we thought about health and the practice of health is different than what was traditionally used, and we are now proceeding in in a different direction. So I think here in this time of COVID, a couple of things stand out. Certainly preventative care, we all know, is an extremely important aspect of medical practice, that it causes significant improvement in health, that access to preventive services can prevent both disease and early death. At no time, probably in recent history, has preventative health become more important, obviously, than with the COVID pandemic. And even though there has been terrible lapses in the institution of preventive aspects for individuals during this time, without question, this really brings up the importance of good public health and preventative issues. So I think that a lot of things that women ask during this time is that, I can't get to, to the doctor. Is there going to be a deterioration in my health? Are there certain things that I should be doing during this time of COVID that are not going to occur? I think a lot of people always think of the annual examination and they think, oh, should I, what's going to happen? It's already been 6 months. I missed my annual visit. Do I need to go for, cervical cancer screening, Pap test? Do I need to go for my mammogram, for breast health? What is happening for people that needed to go for colorectal screening? I think one thing that patients need to be aware of is, obviously, if you are truly sick, that you should go seek medical care. That if people think that they are having chest pain, they're having heart attack, they're having stroke, they do not, should not be worried that they are going to contact COVID going to the hospital. Hospitals do not want you to become ill there any more than you want to become ill there. And a lot of things have been put in place and strategies to protect people's health and to make institutions as safe possibly that they can be with different interactions for patient care. So again, as I said, when we talk about though just routine screenings, a virtual visit can be highly effective. What's happened to my particular specialty in gynecology is that a lot of women now know that annual Pap smears have really are not the regimen, that we have gone to a risk-based assessment of testing. That not only are people in certain age groups having Pap tests, they're also doing HPV testing, which is considered to be one of the main etiologies of cervical cancer. And so it's allowed people to have additional information and for us to space out the interval at which certain screening tests are done, so that people do not necessarily physically have to go to the doctor on an annual basis. If people have an ongoing, disease process, or they're in certain high-risk groups, or their doctor says you have a condition that needs to be seen on in person at intervals, then people need to do that. Otherwise, as I said, some of the other strategies can be quite effective. Should people have some sort of annual contact with a provider? Probably so. But this could be a intervention really based on age, where maybe you would review what your health goals are for the year. You would review where you currently at, issues perhaps of weight reduction, exercise, a preventative improvement of health strategies. I know one thing that recently is of great interest here with the NAACP is the effect of cigarette smoking, which still, oddly enough, is very prevalent in our population, and the consequences of lung cancer, which actually is the #1 cause of cancer death, and very prevalent in our community. So again, these kinds of assessments do not need to necessarily to have a physical one-to-one interaction in person with the provider. These strategies can be discussed in a virtual platform. If somebody has been smoking a lot, they need to have CAT scan, which is recommended for people that have long-term smoking history. That can be ordered and put in for the patient. So and the other advantage to communicating with someone on an annual basis virtually is so that when you have an emergency or you have a situation where you need to communicate with a practice, that practice is aware that you have an association to them, and that they have accepted you as a patient, and that they really have some responsibility to you also, and that they need to connect with you at the time that you are now approaching them. Next slide, please. So we spoke about some preventative measures. So can we go on to the COVID-19 and pregnancy slide, please? So I just want to make some comments, obviously, about COVID-19 and pregnancy. So just some general statements about it, that pregnant women are not more susceptible to COVID-19 than are non-pregnant women. COVID-19 is not a contraindication to someone being pregnant. That for women of color, when we become ill with COVID-19 or pregnant women across the board, that they can become severely ill and that they can be more likely to have an intensive care admission than they would be in the non-pregnant state. The one thing that statement is, though, is that there is not an increase of a mortality that is noted from the pregnant to the non-pregnant state. In other words, that if you are pregnant, you are not more likely to die of COVID-19 than you are in the non-pregnant state. But clearly, this is not something that one wants to, experience ever in life in either, pregnant or non-pregnant. That people want to take all precautions that have been recommended so they, do not contract it. We all know that women of color that certainly bear the brunt of a lot of the adverse outcomes that are associated with with COVID-19, that people have loss of jobs, or they have jobs that they must go to regardless of the fact that they are pregnant and put them and are in a high risk situation. There is no mandate for disability for people because they are pregnant and they may be in situations where they're at higher risk of contracting COVID. These become decisions where people probably have to speak with, their individual employers or, with their coworkers to see, even in addition to things that are suggested to decrease the risk of one becoming ill, what other arrangements can they make to decrease the chances of them contracting COVID?
Dr. Banks, Dr. Banks, as you're kind of wrapping up here and we're heading into the next presentation, what you shared is so crucial about, having a preventive care provider, someone who knows you and you know them. What you have shared is really invaluable about the, the importance of understanding as a pregnant woman that it doesn't place you at higher risk, but you may have higher risk for complications. Summarizing your presentation, and I know you still have a few slides to go, we can kind of circle back towards the end. Is there one main message that you have for people regarding susceptibility to COVID-19, what women should be looking out for? And then we're going to go ahead and transition to the next person after that summary.
Well, I think that one of the main things that, people should have is that they should know what they are going to do, when they become ill. They should know who they are going to reach out to. They should know where they are going to, go for care, that if they are pregnant, that they should have made sure that they have established, prenatal care early so that they can have screening, so that they have a provider that they can reach out in contact with, and that if they are caught in the circumstances that, let's say their initial initiation into the prenatal system at the time of at the time of COVID, that they make sure that they get appropriate referrals so that they can have ongoing prenatal care. I know that we're a little bit pressed for time, but I know everyone is aware of the relationship that and the situation of maternal mortality, here in the United States, where globally maternal mortality has been decreasing. Here in the United States, it has been increasing, and particularly, with women of color, with Black and brown women. And this is, unethical. It's not moral. It is not acceptable. And I think that one thing that we have to, to keep in mind is that we have to be vigilant for other situations that can occur in pregnancy, and that we want to make sure, as I said, that we do have good prenatal care, and that when we have complications, that they're taken care of in the appropriate manner. The other thing that I would say, just along with COVID and just with prenatal care, and I'll end with this, is that, we have to be careful that when people say, oh, that, we have comorbidities, that, the people understand that it's just not Black people that have comorbidities. Other people have comorbidities also. Diabetes, hypertension, these are the diseases that are of our times, that are seen, cardiovascular disease, seen worldwide. But other countries, what we know, that they do not have the mortality rates, that we have, because people have access into healthcare. And even though people do have other health issues, these other health issues are managed so that when the person becomes pregnant, they are in a manageable risk and that they can have good outcomes if they are properly taken care of. We need to be very careful, about blaming people for comorbidities and make them feel that the reason that they are sicker is because of something that they are doing.
Dr. Banks, thank you so much. It's a very empowering message. As we're pulling up Dr. Shaban's PowerPoint, because he's going to be next, that message of getting a provider, knowing that provider, having a sick plan, what's going to happen to you, what's going to happen to your family members or your children if you were to become ill. Who do you reach out to when you become ill? Those are very, significant, very important messages for us to take away, and also to sort of manage and help manage our chronic illnesses and work on those to reduce our overall risk. This is a perfect segue into our next presentation by Dr. Hamid Shaban. He's the Chief Medical Officer of St. Michael's in Newark, New Jersey. He's Assistant Program Director of the Internal Medicine Residency Program, and he's going to talk to us today about current disease state of COVID-19 and its impact on our community, and how he's going to pack all of that into about 8 minutes or so. We're not sure, but I'm sure if we can find someone to do it, he's going to be the one to do it. So Dr. Shaban?
All right, good afternoon. Thank you for that introduction. I'm honored to be here at this conference. I was entrusted with the job of presenting about the current disease state of COVID-19 and its impact on our community. Next slide. So I have no disclosures. Next slide. Next slide. So I'm going to talk about the global epidemiology. This is a great dashboard at Johns Hopkins. So as of today, we have over 34 million confirmed cases of COVID-19. In the United States, it's approaching 8 million. As far as deaths are concerned, we have over 200,000 deaths related to COVID-19. As with regards to global recoveries, it's over 25 million. In the United States, we have over 2 million. Next slide. And this is the COVID-19 tracker. As of March and April, we saw most of the cases concentrated on the East Coast in New Jersey, New York, Connecticut, but now it's moving throughout the United States. Most of the cases we're seeing in the Midwest, Florida, Texas, and California. With regards to deaths, again, most of them were concentrated in the East Coast, but now we're seeing more deaths in Florida, Texas, and California. Next slide. And with regards to hospitalization rates, This is what we have been seeing since COVID-19 made its surge into the United States. The elderly at highest risk of being hospitalized. They're more at risk of developing severe COVID-19 disease. In the 50 to 64-year-old age group, the comorbidities that Dr. Banks touched upon, obesity, hypertension, and diabetes seems to be the prevalent risk factor for developing severe disease. Next slide. So what's the story of COVID-19 in New Jersey so far? Next slide. So this is a dashboard as of October 1st. So far, we have over 200,000 total cases. Over 3 million PCR tests have been reported. Now, in March, April, most of the cases were concentrated in Hudson, Essex, Passaic, and Bergen County. But now we're seeing an uptick in number of cases in Ocean and Monmouth. Actually, it's throughout New Jersey, and that has brought some concern of a second wave hitting the East Coast. Next slide. As of September 28th, the daily percent positivity was 2.47. Yesterday, I checked the dashboard. It's now 3.69. Next slide. Total hospitalizations in October 1st, it was 528. I checked the numbers last night. It's 650. Next slide. Individuals on ventilators as of October 1st in New Jersey, there were 36. Yesterday, I checked. It's up to 60. This is concerning. These are all, we're not going in the right direction right now in New Jersey. Next slide. So racial and sociodemographic disparities. Next slide. So it's becoming evident that nationwide, Black people are dying at 2.3 times the rate of white people. Interesting enough, the highest infection rates are seen in counties with more predominant white people. But when we look at death rates, African-American predominant counties have the highest risk. Number 20 on that list is Essex County, New Jersey. Next slide. So this basically highlights what's going on in New Jersey. The first pie chart looks at all cases by race and ethnicity. 17% is of Black people is attributed to COVID-19. Hospitalizations, 20.1% attributed is seen in the Black population. With regards to deaths, 18.3% is attributed to, is seen in the Black population. Next slide. This is a breakdown of the counties in New Jersey. The numbers show the number of cases per 10,000 residents of a given race. And as you go through the counties, you see the clear disproportionality of the incidence of COVID-19 with regards to Black and Hispanics versus whites. So clearly, Blacks and Hispanics are being afflicted with this virus more than white people in New Jersey. Next slide. This basically looks at the COVID-19 cases by race and ethnicity. As the old adage goes, when China sneezes, America gets a cold and Black people have pneumonia. As number of cases are, when we look at the number of cases, white people is 38.6, Hispanic 32%, Black 19.8%. Next slide. But when we look at hospitalizations, we see more, it predisposes people of color to severe disease and the requirement for hospitalization. Next slide. As with regards to deaths, white is 49.9% of total deaths, Blacks 22.2%, Hispanics 17.2%. Next slide. And this is what we saw in predominantly March and April, the disproportionality with regards to cases, hospitalization, and deaths by race and ethnicity in New York City. Clearly, Blacks were getting more cases. Blacks were also being hospitalized at a higher rate compared to whites. And Blacks had a higher rate of deaths. Latinos had 260, and whites was 123. Next slide. So initially in March, April, there was talk in the science community that maybe there was this genetic predisposition that was putting people of color at risk for severe COVID-19. But when we break down poverty level in New York City and looking at cases and hospitalization and deaths, we clearly see that having a very high poverty level in New York City was associated with higher number of cases, higher number of hospitalizations, and higher number of deaths. Next slide. Multivariate analysis of the predictors of COVID-19. So if you were Black, you had a higher risk of getting a severe infection and a high risk of mortality. If you were uninsured, you had a higher risk of getting severe COVID and high mortality. Household occupancy of more than one person per room was associated with a high mortality, and days since first case of diagnosis, meaning if you had mild symptoms and you waited 4, 5, 6 days before presenting to seeking medical care, you had a higher risk of mortality. Next slide. So is this something foreign to the United States? They look at this in England and Wales, and they clearly saw in an age-adjusted analysis that Black males were 4.2% more likely and Black females 4.3% more likely to die from COVID-19 infection. Next slide. These are two studies looking at ethnicity and COVID-19 outcomes from the UK, Open Safely and ISORIC. And the bottom line is that if you were a person of color, you had a higher risk of death compared to white people. Next slide. So what are these factors influencing racial and ethnic minority group health? Living and work conditions, work in essential industries with increased exposure, lacking PPE and paid sick leave. Unfortunately, people of color cannot stay at home. They cannot afford to stay at home. They had to show up to work. Residential segregation by race linked to many adverse health outcomes and underlying health conditions. Blacks are more likely to live in a higher housing density and poor access to healthy foods. Multi-generational households and limited space make it more difficult to protect family members and do that social distancing that's been advocated by public health experts. Underlying health conditions, access to care. Minority groups are more likely to be uninsured. The language barriers and financial implications of missing work to receive care. The comorbid conditions of obesity, hypertension, and diabetes are linked to an increased severity of COVID-19 and increased levels of chronic stress due to structural and systemic racism and everyday aggressions. Next slide.
Dr. Shaban, these statistics, they are overwhelming. We're living with them every day, and it really does tie into what Dr. Banks was talking about sort of existing disparities in prevalence of disease and issues that predispose us to having worse outcomes when it comes to COVID. And as you're wrapping up in your last minute, from the data that you're presenting to us, what are the bullet pointed items that we need to take away from this presentation in terms of, what is the most important data we need to focus on in your last minute?
So the most important thing to focus on is that, yes, we're clearly seeing a disproportionality. There's definitely a healthcare disparity when it comes to COVID-19. We're seeing more Blacks, more Hispanics getting severe COVID-19 compared to the white counterparts. We're also, there's data, the slides that I wanted to show that basically the interventions of remdesivir and dexamethasone. Clearly, if Blacks and Hispanics show up to the hospital early, soon enough, not waiting days, it has shown to be of benefit, clearly. So that remdesivir trial data is beneficial specifically to the African-American population. And it's a relatively safe drug based on that data. I'd also like to emphasize the importance of social distancing, hand washing, and obviously wearing a mask. That is shown to be a benefit. And then what can we do? Implement standardized protocols and quality improvement initiatives, particularly in facilities that serve large minority populations. Identify and address racism that hinders patient care and communication. I think it's something that needs to be implemented in our academic training in medical school and residency training. Provide interpretation services to patients. Connect members of the community to resources that can help patients with underlying conditions adhere to care plans. We need to learn more about the social and economic conditions that puts patients at risk for severe COVID-19. Encourage truly open communication between individuals and care providers, and obviously educate. As Malcolm X said, education is the passport to the future, and for the future belongs to those who prepare for it today. Next slide. And basically, I just wanted to go over health equity. That's when every person has the opportunity to attain his or her full health potential, and no one is disadvantaged from achieving this potential because of social position or other socially determined circumstances. Thank you.
Thank you so much for both you and Dr. Banks. And as we're pulling up Dr. Momadou's presentation, the recurrent theme for both of you so far in the face of this overwhelming data is the importance of this communication between our communities and the health community, our communities and health providers, be it women, women who are pregnant, be it another person who has a chronic health condition and needs to get that condition under control, or just report to the hospital or to a provider when they're feeling ill. That theme so far going through both of your presentations. And I'm curious to see whether or not there's going to be additional discussion of that theme with Dr. Momadou. And I imagine that there will be, because Dr. Momadou is actually a board certified child and adolescent psychiatrist, and a board certified adult psychiatrist as well. He's well known in the Philadelphia region. He trained in Jefferson. He's the chief medical ambulatory officer who oversees behavioral health and primary care at PACE. And works also in the FQHC there and with the Atlanta Care Health System. So I'm not going to take up any more of his time. This 8 or so minutes, how he's going to wrap our minds around mental health issues during COVID-19 in that amount of time. He's the perfect person to do it. So Dr. Momadou.
Thank you for that introduction. Good evening, everybody. So we are here to talk about mental health impact of COVID-19. Everybody, no matter what level of cadre you are in this world, has had the impact of the pandemic, and the impact of pandemic has led to multiple stress levels. Next slide, please. So, what are the effects of stress? We all know that stress causes firing of stress hormones, which people know as adrenaline and cortisol, and these trigger our body's response and causes us for flight and fight responses, which means our heart races, our breath quickens, our muscles tense, we are ready for action. It's almost like you are being chased by a lion. You just want to run and you want to be ready. So for an immediate effect or short-term situations, stress can be very beneficial to our health. However, if our body doesn't stop firing in case of chronic or continuous stress, it causes symptoms that affect our overall physical and mental well-being. It causes us to be irritable, it causes severe anxiety because we're anticipating another form of stress, and it causes depression because we feel a sense of hopelessness and helplessness. Sometimes we have physical response to stress, headaches, and poor sleep. Next slide, please. So, there are many other events that occurs during stress. It is evident that the direct and indirect psychological and social effects of stress as a result of this pandemic are pervasive and definitely affects our mental health now and even in the future, because there is a lot of sequelae of this stress that's going to occur later in life that we are not even aware of because we are still in the middle of this pandemic. Furthermore, we know that the virus that causes COVID-19, the SARS-2 virus, has an effect on the brain itself. It triggers immune response in the brain, and this also has adverse effect in brain function and immune response, in brain function and mental health issues with patients. We know that mental health we view as a brain disease. So if this virus is in our brains causing immune responses, it definitely has long-lasting effects that we may not even be able to quantify. Additionally, it quarantining people when everyone has to stay at home, which is the best way to prevent this virus currently, has led to widespread concerns, led to loneliness. It has affected social isolation, social well-being. It has increased our anxiety level again, has deepened and worsened depression. It has increased negative feelings and has increased harmful behaviors. There has been reports of increase in self-harm behaviors and suicidal behaviors during this COVID as compared to other times. And there are concerns about the practical implications of this response, like loss of jobs and financial difficulties. More specifically, people who have been known to have pre-existing mental health issues have had greater difficulties because there is a decrease in accessing mental health support and services under these pandemic conditions. And the effect of COVID-19 on the mental health, not just of an individual, but of the family members, especially the children at home and the elderly, has been profound. Patients who have survived severe and life-threatening illness are also at risk of what we call post-traumatic stress disorder and depression. The effects of working from home, which is also part of this pandemic, has led to, of course, social isolation and has disrupted many social opportunities important to physical and psychological health. Across our society, the pandemic has led to a sense of loss that stem from losing direct social contacts and also range from loss of loved ones to loss of employment, loss of educational opportunities, loss of recreation, loss of freedoms, and loss of support. Next slide, please. So, although the whole population, as we know, is affected by coronavirus, specific sections of the population will experience it differently. Some groups may face, as we've already heard, a disproportionate mental health impact during the COVID-19 pandemic, like people of color, migrants, people of various ethnic groups. People of color experience more serious illness and deaths than white people. For instance, our own children, African-American kids, statistics showed that between the ages of 5 to 12 years old, they have twice the incidence of depression and suicide than that of white children. And that has just gotten worse with the pandemic. Migrants with poor and crowded housing conditions have led to higher risk of spread of COVID. Racial and ethnic discrimination with racism have led to toxic and chronic stress among people of various ethnic groups. And you heard what I said about chronic stress. It increases anxiety and worsens depression and increases harmful behaviors towards self. Now, let us look at what this COVID-19 has also done to some special population and what the effects are. Next slide, please. To the children, the young ones, the families will be affected by school closures. There might also be effect by exposure to substance misuse, which occurs in the house when people are all together, increase in domestic violence, increase in child maltreatment, absence of free school meals, leading to hunger in some families, overcrowding like we mentioned, loss of parental employment, disruption in social networks. This also has profound implications in child development. We know that one of the ways to prevent, apart from social distancing, is the wearing of masks, face masks. Early childhood development for very young children, they need to have facial recognition and facial cues for them to develop sense of understanding of facial norms and body language. This is becoming missing. And so there is a prospect that we're going to have children who are born, who are very young, that are going to have deficit in their ways of response to facial issues as the future goes on. Next slide, please. For older adults and those with multiple comorbidities, they are particularly affected by issues of isolation and loneliness. There are also end-of-life care issues. Imagine older adults who are at their end of life, being very sick and hospitalized, and they are not allowed to have their family members at their bedside towards the end of life. That's a very huge issue, both for the families and for those that are sick. Bereavements, a lot of older folks have lost a lot of people because we know that this virus has affected disproportionately the older adults, died more than the younger ones. There's also a digital divide. We heard about use of telemedicine But older folks have difficulties maneuvering some of these issues. One, there's lack of easy access to the digital means, and also lack of equipment for it, and their understanding of the use of these digital means. Next, please.
Dr. Mamadou, not to
Yes.
interrupt, but just wanted to say in your last minute, and part of the reason why we're advancing the way that we are is because we have so many good talks and we're leaving some additional time for questions and discussion. And I want to let the participants know you can continue to leave questions in Q&A and chat, and we're going to circle back to those at the end. But could you, again, like the other panelists did, kind of from your presentation in your last minute, kind of really talk about what are the take-home points that we should know about obtaining psychiatric services during this time of just great overwhelming stress? What should we be doing?
So I would encourage everybody to, one, be aware of the impact it has on us, recognize it, and understand and accept it. And I would encourage everyone to please seek professional care and professional help at these difficult times, despite the fact that professional help has also diminished and decreased, because there have been many closures of some clinics who do present and help with fostering mental health care. But that will not prevent us from having, encouraging each other to seek help, because the impact of depression and anxiety caused by COVID is very devastating. And we don't want to lose anyone else to mental health reasons besides the virus itself. So we encourage everyone to seek help. We encourage everybody to be educated and learn about it, and also to try to minimize the stigma associated with mental illness during this period. Thank you.
Dr. Mamadou, thank you very much. And again, continuing that thread of acknowledging what's there, either a preventive illness, a current condition, and then seeking help. A very important thread as we're heading into the next conversation with Dr. Innocent. She's the Senior Director of Health Programs and leads the development and management of NAACP's program and policy agenda, advancing equitable solutions to health disparities for African Americans and public discourse about the intersection of health, or the intersectionality of health, with so many different areas, social issues, education, economic development. She has a Doctor of Philosophy degree from Johns Hopkins, her bachelor's from Columbia, and we are thrilled to have her contribute to this conversation. It's a very important conversation. And again, with the 8 minutes or so that you have, really kind of, kind of allowing us to frame our minds around COVID-19 as it relates to our communities now in policy. So Dr. Innocent.
Thank you so much, Dr. Johnson, and good afternoon, everyone. So happy to be with you and really appreciate your time today. Next slide, please, or first slide. I was asked to speak about what is happening with the Black community in particular. And the title I was given is Community Forgotten. And I think it's important to keep in mind that, that title as we have this discussion. Next slide, please. And you're going to certainly hear about a number of themes that will be repeated from what you have heard before. So first of all, just looking at the death rates, and I focus especially on the right side, the age-adjusted death rates in particular really show the stark difference between racial and ethnic groups. So where we really see how for Blacks, for Latinos, or Latinx population and indigenous people, they are more than 3 times as likely to die from COVID-19. And even with Pacific Islander Americans, almost the same. And with Asians, actually the same. And we'll keep in mind that Asians actually have the lowest actual death rates. But when we think about, making the appropriate adjustments based on the different age categorizations, if you will, within each of the groups, even Asians are more likely to actually die. Next, please. So what is behind that reality? You've heard a lot about this already today. The reality is it is largely driven by the social and economic conditions that people face day in and day out and over their lifespan. So certainly people's ability to be able to have access to healthcare and certainly have access to timely healthcare is really critical. And we know about the challenges regarding both coverage and people's ability to actually get care in sources in places that are relatively near to them. And we certainly know about the issues with quality of care. That actually really largely determines, it's been proven, about 20% of what it is that people actually experience in terms of health. The other 80% is really tied more to broader social factors, or the social determinants of health, as they are often called, including employment, the type of employment that people have, the housing conditions in which they live, their educational level, the quality of education that they have, the income that they have, and quite frankly, the wealth piece is a conversation unto itself. The reality is, from our perspective, those are all really a function of the legacy of the racialized experience that Black people have had, and others, quite frankly, have had in this country, and the discrimination that has resulted from it. Next, please. So when we talk about the impact of social determinants on health, this isn't actually something that is new. It's been discussed for a really long time. And when we talk about Black health in particular, Dr. W.E.B. Du Bois first talked about this more than a century ago. In doing the great work that he was doing, looking at the conditions of the Black population in our country, he recognized that there are some real differences, not just in the health status and the health outcomes, but also in the lived experience that people had, right? So literally, he organized the Atlanta Conference of Negro Problems. And in 1906, the first conference took place. And as a result of the conversations, if you will, the discussions that took place then, there was a call for greater use of preventive medicine. Does that sound familiar? As well as some real improvements in, and I quote, the sanitary conditions, education, and economic opportunities of Black people, all seen as a way to actually improve both the health status as well as the differences across racial and ethnic lines, right? The differences with white people. And what this really means is that from, if you really think about it, this current pandemic really has demonstrated not just the reality of what social determinants really mean, but also the significance of the great work and the argument that Dr. Du Bois had made more than a century ago, the extent to which we haven't really made the kind of progress that we should be making, and the reality of the persistence of racism in our country. Next, please. So what can be done? We are in a crisis that is national in scope. It affects different parts of the country differently, but it is a national crisis. And really what needs to happen is an appropriate federal response. It needs to be at the national level, it needs to be with federal government. We can go on about what has and has not happened, but here's the reality of where we are right now. There are a number of options that are before us. And when we think about the racialized experience that by and large, so many people experience in this country, it really has been institutionalized through policies, through public policy at the federal level, but also at the state and local levels. So I'm sticking with the national level right now. First and foremost, we have a health insurance crisis. We had a problem before. We had the Affordable Care Act, which I'll talk about in a minute, that really helped to close that gap, helped to ensure more people had coverage. Since 2017, figure out what the difference is here. We have actually seen an erosion. We've actually seen more people become uninsured once again. And then we are where we are today. So we've got people who have lost their coverage through their jobs. We've got people who were getting insurance themselves, who no longer have income or have reduced income and can't continue to get insurance coverage. And this is something that clearly, based on our current model, has to be addressed, because ultimately it's critical for people to be able to get care. It's critical for the healthcare system to be able to deliver care. And one of the big areas that we're pushing for at the National Office of the NAACP is really to expand Medicaid at the national level. As you likely know, Medicaid is a federal state match. States and localities are suffering. Their budgets are suffering right now. And so what we really need is for the federal government to step in to ensure that it is expanded everywhere, including in the areas where Medicaid has not been expanded. and that we look at the program in a way that makes a lot of sense for what it was initially intended to do and what it can really do right now. Number two, the HEROES Act, which you probably have heard about, passed in the House in May. I think it was the end of May. There was a renewed version. I think it was quite a bit of concession, reduced by $1 trillion. It's now about 2.1, I think, $1 trillion. That's been passed in the House. It's just sitting there. It's an incredibly comprehensive stimulus package, really looking at funding, not just for businesses, now also for the airline industry. It's also got funding for schools. It's got funding for state and local governments to really be able to ensure the availability of appropriate resources. It's got funding for individuals, right, to be able to help to provide some relief to individuals and to families. It's an incredibly comprehensive package. It needs to pass. It really just needs to pass. And does this really need to happen after the elections? No, it does not. And then the ACA. So we've been hearing for, ad infinitum about how it needs to go, it needs to be repealed. It is the most comprehensive effort to really reform health care in our country and our healthcare system that we have seen in multiple generations. We need to actually protect it and build on it rather than repeal it. Next, please.
Dr. Innocent, again, your presentation is powerful. You've taken us through the deep historical context of the why we see what we're seeing. In your last minute of the presentation now, can you lead us through, in addition to the action points that you've already given us, the most important action points you want us to sort of leave this presentation with in this conference with moving forward in your last minute?
Absolutely. So thank you so much. So to move us toward a stronger and a healthier nation, we need to have a more prevention-oriented approach in all of our policies, as we've heard before. And this certainly includes both healthcare and our broader social policies. So in terms of coverage and delivery, in terms of improving social conditions for all people, we really need to focus on efforts that will really be working ultimately to optimize health and well-being for all people, and not separate what the healthcare system can do and the reality of what people experience on a daily basis and what both really mean for people's health. And in particular, I think it's really important for us to look at both developing and implementing policies through a lens that recognizes the reality of racism. And that means that we need to have a racial equity focus in both defining and putting policies in place. And honestly, this is something that I believe that America owes to Black people, and it really owes itself as a nation if we really are going to be the very best that we can be.
Dr. Innocent, as always, and I've heard you speak before, very powerful, very actionable, and that is actually the perfect segue into our last speaker in her 8 minutes of presenting. It's Ayo Sanderson-Wilson, who's a lawyer and the founder and board and chair of Empower the Village, a data-driven nonprofit organization founded in 2018 that develops, guides, and implements breakthrough, scalable strategies that empower people. So you've given us some action items, and she's coming from the standpoint of the public, the private, the nonprofit world, how we can work together to come up with actionable solutions. So Ayo, your 8 minutes are up.
Okay, thank you so much, Dr. Johnson, and thank you to all the panelists. I am the lawyer bringing up the rear, so although I did attend Johns Hopkins University, some of my best friends are doctors, I am not one. I fancy myself a community activist and someone who just cares about our community, and that's what Empower the Village is all about. We do have a video that I'm hoping will be queued up, which will walk you through in about 3 or 4 minutes what we've been doing within the community to empower the village around COVID-19. And I'll talk a little bit more about beyond COVID-19, because we will get through this crisis, but what will we do on the other side? So if that video is ready and can be queued up. Don't hear the volume.
We're
We're here from Empower the Village, Inc. It's a nonprofit organization focused on African Americans and the needs of our community. And unfortunately, given the statistics and the data that we've all seen, African Americans are suffering greatly from this disease, and we have a higher proportion of us who are dying from the disease and being hospitalized because of it. So as we look around, we try to figure out where the gaps are in terms of the needs for the organization. And Io Sanderson Wilson, as board chair of Empower the Village, partnered with my executive director, Cheryl Easley, and we started brainstorming about what we could do to make sure that our community is as healthy as it possibly can be. We always believe with everything that knowledge is power. And in this case, certainly knowing your status with COVID-19 is incredibly powerful. So today we partnered with Calvary Baptist Church and Zufall Health Centers to bring a mobile clinic, if you will, for people to come and get free testing, because we recognize that it's not always accessible or affordable to do that.
As Io said, there are many different organizations that with whom we have natural alliances to bring COVID testing to the communities that might likely be underserved in Morristown. Today, we've already tested over 100 people, and the need is even larger. So we are pleased to announce that while this was our inaugural event, we'll be having another testing day next week on June 20th, and hopefully we'll have an even further reach in our community. It's been our pleasure to serve the community today.
We have a van that we have placed here in the parking lot where we have people coming in with their cars, and they're getting registered for the event. And we're also providing education on the virus. The test takes about 5 minutes. It's a quick test. And after that, the people who are involved get the results back in about 2 days. You can come registered, or you can come without an appointment. We accept walk-ins, anyone's welcome. We're hoping that more people will come and actually get tested for the virus.
My name is Todd Easley. I'm the president of Sigma Zeta Lambda chapter of Alpha Phi Alpha Fraternity Incorporated. On behalf of my brothers, it is our pleasure and honor to
Okay, so it cut a little short. Are you all hearing me now? Okay. So we wrapped up that video with the speaker from Calvary Baptist Church. And what I'm here to talk about is how it takes a village. We've all heard about the data. We've heard about the challenges. I have personal experience, unfortunately, with loss related to COVID-19. I lost my grandmother in April as a result of her contracting COVID while she was in a nursing home. And we brought her home. There were a lot of challenges. We did not have some of the economic challenges that we talked about earlier. So just know, money is not going to save you. We're going to have to save ourselves. We have to get together and figure out how to solve this together. The government is not going to save us, as we know, unfortunately. So we've got to be as creative as we possibly can be. So Empower the Village is all about getting the village together to support ourselves with our allies, of course. So for me, it's really all about the information. Knowing your status is critically important. Getting tested is very important. In the beginning of this pandemic, and even in some places today, people do not know how or where to get tested, or don't have a trusted place that they want to go. So what we did was, first inquire as to whether or not there was free and affordable testing that did not require insurance or symptoms for people to get tested. Vast majority of people who are positive don't know that they're positive, may not have symptoms, but they can spread that to people who might die and have severe symptoms. So that was critical for me personally. If we had known that my grandmother was sick, we probably could have done things a little bit differently, but we did do everything we could possibly do. There are many people out there that don't have insurance, don't have the relationships with the doctors that I and my family happen to have. And so we worry about that. We worry about all of our people. But having Calvary there to provide us the space, having Zufall to bring the HCPs together, the healthcare providers that we needed, the Alphas there to organize and spread the word along with the rest of the community, meant that hundreds of people who would not know their status now know it. I want to touch on a couple of things. Testing is important. I know that you hear sometimes, well, it's just a point in time. What does it really mean? It means a lot. knowing your status means that you can keep yourself healthier. You can go and get taken care of sooner. And I'm talking again, but you can take care of yourself sooner. You heard some of the doctors talk about that early intervention and getting healthcare quickly when you find out that you're positive, and the outcomes can be better. You can, of course, avoid the spread to other people. But beyond that, from a mental health standpoint, we're all living in the state of anxiety that the doctor spoke about, and stress, and not knowing where you are at any given moment with regard to being positive or negative. It wears on you. That anxiety is real. And so there are opportunities to get tested, and people should take advantage of them, because you just want to know and know, at least at that moment, that you're not positive, or if you are, you can take care of yourself. So Empower the Village more broadly, we are about not just health and wellness, although that's a critical part of it. There are 3 other areas of focus that we have, economic prosperity being one of them. Another is policy and power. We're doing a lot of work around the election. And last but not least, academic excellence and career readiness. So this pandemic has brought to light disparities that many people who are participating in this conference were aware of in all 4 areas. But now we have an opportunity to get together as a village and figure out how we're going to accelerate transformative change around all of these areas. So sadly, this pandemic has shined the light on something that has been around for a long time, but there seems to be an increased interest in what we're doing. And Dr. Johnson knows, she and I had a conversation about the fact that we are at an inflection point in this country. We've kind of hit the lottery, sadly, on attention, on the disparities that we experience as a people, but that will pass. Just like the Oprah shows used to be about, someone who hit the lottery, they won $20 million, and then 2 years later, they were destitute. They lost all their money. They didn't have a strategy. They didn't have information. We have to make sure that does not happen to us. We've got to work together. We've got to figure out how to solve our problems. We can do that in a strategic way collectively, but we have to acknowledge what the issues are and rally the troops. We've got plenty of troops out there. They just need direction. They need support, and we've got to get that village working. Thank you.
And Ayo, do you have any, as you're kind of wrapping up in your last thing before we head right into the question section, are there any events or activities that your organization, Empower the Village, is going to be doing related to COVID-19 or any other kind of testing?
Absolutely. So what you probably see on your screen, we have a flyer up. So we've been doing intermittent testing, free testing for COVID-19, no insurance required. In the Morristown area, we have an event coming up next Sunday, October 18th, from 11:30 to 4:30. If you want information, you can go to our website, but you can also just email us at info@empowerthevillage.org. But we have that event next Sunday. We're also offering the flu shot, so you can get your free flu shot and or COVID testing. No registration required for the flu shot. Registration is required for COVID testing, but no insurance is required. So yes, there's an opportunity coming up soon. We will continue to do ongoing testing. With regard to other areas that we're working on, Dr. Johnson, as we spoke about, health is tied to wealth, right? It's tied to wealth. It's tied to everything else. We're about the restoration. Empower the Village is about the restoration of health, prosperity, peace, and power to the Black community in particular. And the intersection of these things has been talked about throughout the day at this convention. Black businesses is another area of focus. If you think small businesses are struggling, Black businesses are struggling even more. So we've got to work together to make sure that we're supporting each other, not only with our health, but also with our businesses. We have an awareness campaign that's launching in November called Every Friday is Black Friday. The idea is that, we all know about Black Friday. It's the time to spend all your money every place else, but every Friday is Black Friday. We're encouraging everyone to think at least once a week, hopefully more, about Black businesses and supporting Black businesses on a regular basis. So that is one of the campaigns that we're hoping will go viral and ensure that our businesses get the attention and the support that they need. And so, stay tuned for that. Every Friday is Black Friday. So that, coupled with taking care of ourselves, is the most important thing we can possibly do right now. So thank you.
All right, guys, I know that this has been a lot of information. I'm kind of summarizing some of the questions, and I answered one question that was in the chat. We only have about 7 minutes left total. And so I'm going to kind of jump in and ask a question that any of the panelists can answer. Perhaps Dr. Innocent or Dr. Shaban can answer this, because we've heard a lot about the vaccine, about the COVID-19 vaccine. And like Kamala Harris, most of us want something that is safe and effective from the scientists. But given these issues of distribution and access, how can we ensure that once we do have a safe and effective vaccine, that it is actually reaching our communities and these communities that are going to be losing insurance and jobs and access and care? How do we create a policy, or how do we strategize? And even IO, how do we strategize to make these things available in our communities?
Absolutely. So one of the things that was important before we started down this path was that we were trying to figure out what the government was already doing with regard to testing, right? And what we found out was very little. So what we decided to do was to reach out to the community organizations, but also there are health clinics, and in this case, Zufall Health Clinic, that was doing testing, COVID testing, but in rural areas and with the farm worker population. And so we had to get them, and they were very happy to do it, to agree to come to the more urban areas where Black and brown people were, and they were happy to do it, but they needed a place, and they did not know how to get out the folks to come get tested. So we partnered with them. So we were the engine to get people out, make them aware, make them feel comfortable, and working with the churches. I think that there's an opportunity here. And I know from talking to Zufall Health and others that they are looking for partnerships, because when the vaccine is ready, we've got to be ready ourselves as a community to come out and get vaccinated. So just like we're doing this flu clinic where people are coming out just for the flu vaccine, hopefully soon, in a couple of months, or when it's ready, when it's right and when it's ready, we will be partnering again to make sure that people can get the vaccine for COVID.
That's exactly right. The partnerships that have to happen with trusted voices, trusted sources in communities is going to be very, very essential. And along with that, information starting now about vaccine development and initial plans for vaccine distribution need to be shared with communities as well. There's a real black box around this process that for a lot of people feels foreign, obviously. And the fact that the process in and of itself is being expedited really says to most people, rushed, and are there steps that are being skipped and at whose expense ultimately? And so there is, some real lack of transparency, if you will, and insufficient information sharing that really needs to be part of the efforts now, as I was just saying. And then I throw out also that there is a draft plan for disseminating or distributing the vaccines that the federal government did lay out. And while it looks at a number of key populations, such as the wide grouping of essential workers, what they did not do at any point in time was actually lift up the importance of making sure that Black people can get access to the vaccines as a category. That's a real problem for us. And so, as part of the information, that we're sharing and recommendations that we're putting out there, that's actually, that's actually been part of the response that we've shared.
And, as we're moving forward and as we are promoting access, and we're fighting for access and for opportunity, how can we do so, and this is maybe for Dr. Shaban to answer, when we're looking at the actual providers of care? How do we get more people in the time of a pandemic even interested in participating in culturally competent and effective preventive care services? It's one of the fields that the least amount of physicians want to go into, and it's the most greatly needed. So what's your pitch for getting more people into going into preventive medicine?
I think it's imperative that physicians of color have to go into the community. I mean, we have to promote urban health. I mean, so if you look at physicians right now in America, 1 in 3 physicians are foreign born. So systemic racism is a totally foreign concept to them. I think it's imperative that we start implementing it in training. I kind of alluded to that during the presentation. In our medical school, in residency training, it should be a mandatory elective to urban health, actually going into the community and understanding the mindset, understanding the complexities of healthcare in the inner city. So but definitely I think it's imperative that kids in the inner city see physicians of color. We need to promote, because right now the representation of physicians of color in medicine is up to 3 to 4%. And we need to be there. We need to show them that our community needs physicians like us. And the studies have shown, right? If a physician of color is taking care of a patient of color, the outcomes are much better. All the studies have shown that. So that's basically what we need to do.
Okay, this is Vivian. I have one question for Dr. Innocent. Could you share with everyone the NAACP Region 2 pilot program with Quest Diagnostics, please?
Can you repeat the question? Sorry.
Could you share with the NAACP the Region 2 pilot program that we're developing with Quest Diagnostics?
Yes, sure. So that's coming up, not fully in place yet, but Quest Diagnostics reached out to us a few weeks ago wanting to expand testing, COVID-19 testing availability, free testing, obviously, in some key communities. So we're literally working with them right now to go ahead and do so. And we are looking to start this in Region 2. So largely the Northeast corridor of the United States. We'll probably be looking at about 5 cities, a little bit more to come on that. And we certainly hope that it'll be, can you hear me?
Yes, we can.
Okay, great. That it'll be a successful effort. It'll most likely be happening during a weekend. So again, more information to come. And from there, we'll be expanding it throughout the rest of the country.
Thank you. Thank you
Absolutely.
very much. Thank you to all of our panelists. I think that we received a wealth of information. All of the PowerPoints will be available on the website, the NAACP New Jersey State Conference website. We're developing a health tab, so you'll be able to receive this information and share it with your branches. So again, I'd just like to thank each of you, and by all means, keep your link and come back and join us tomorrow. We will be here. Thank you so much. That concludes the health portion of the convention.